Welcome to the Deep Dive. We're here to really get under the skin of complex professional topics, aiming for true mastery.
That's the goal.
Today, we're tackling something absolutely critical in medicine and pharma, drug-related harm. We're talking adverse drug effects and the science that tracks them, pharmacovigilance.
Right.
And our mission isn't just definitions. It's about gaining that elite professional understanding needed to really manage clinical risk effectively, high-stakes stuff.
Absolutely. And, that starts with the language. It sounds basic, but the terms AE, ADR, ADE, they get mixed up all the time in conversation.
They do.
But professionally, they represent a really strict hierarchy. It's all about observation versus causality. And it dictates everything from regulation to how you actually treat a patient.
Okay, let's break down that hierarchy then. We'll start at the top. The widest net, right? The adverse effect, AE.
Exactly. AE is the biggest bucket. Think of it as just.
Yeah.
Any undesirable thing that happens after a drug is given, no matter how serious, trivial, serious, fatal, none of that matters yet.
So no assumption about cause.
None at all. If the drug was in the picture time frame-wise, it could be logged as an AE. It's purely descriptive at this stage. Very broad.
Okay, so that's obviously too broad for making clinical decisions.
Yeah.
We need a term that actually suggests the drug might be the culprit.
Precisely. And that brings us to the next level down. The adverse drug reaction, ADR.
ADR.
Right. Now, this definition is critical. It's the one that has legal and clinical weight. And ADR is defined as a noxious change which is suspected to be due to a drug.
Suspected. Key word.
Absolutely key.
Okay.
Occurs at doses normally used in man, and it requires some kind of action. So you either need to treat the reaction, lower the drug dose, or, and this is important, be cautious about using that drug again in that patient.
Okay, and thinking like a professional here, what's not included in ADR is just as important, isn't it?
It really is. The definition specifically excludes those minor kind of expected side effects. A little dry mouth from an allergy pill, not an ADR. And it also explicitly excludes outright poisoning or accidental overdoses. We're focused on harm that happens within that intended therapeutic range.
Got it. So AE is anything bad happening temporally. ADR is harm suspected to be caused by the drug at normal doses. But there is a third one.
There is, and it bridges the gap, really. It's the adverse drug event, or AD.
AD. Okay, how does this fit in?
An ADE is any untoward medical occurrence that might present during treatment, but which does not necessarily have a causal relationship.
That sounds confusing. If there's no necessary causal link, why track it? It sounds like a massive headache, potentially recording loads of coincidences.
It can seem that way, but it's fundamental to how pharmacovigilance works and, frankly, to managing legal risk.
How so?
The idea is cast the widest net first, record everything medically relevant that happens while the patient is on the drug. Just capture that temporal association.
So observe first, analyze later.
Exactly. You collect all these ADE reports, maybe thousands of them. Then you apply rigorous causality assessment tools, like the Naranjo scale, for example.
Ah, right, to see if it holds up.
Yes, to sift through the data and determine if that observed event, the ADE, can actually be classified as a probable or definite reaction, an ADR. You start by logging coincidence, and only then do you rigorously look for the proof of causation in the pooled data.
That makes sense. It connects directly to the fundamental challenge in medicine, doesn't it? The whole risk-benefit calculation.
It's the core calculation. Every single prescription involves it.
Yeah.
And we have to be realistic. Risk isn't some abstract possibility. It's inherent.
Yeah, the sources mention incidence rates of 10, even 25% for adverse effects in some settings. That's high.
It is, especially with multiple drugs, polypharmacy, or in elderly patients whose systems might not clear drugs as efficiently.
So the clinician is always weighing things up.
Always. How big is the risk versus how big is the potential therapeutic gain? It's context dependent. Think about chemotherapy for advanced cancer.
Okay.
The risk of severe bone marrow suppression, neutropenia, it's huge.
Yeah.
But the potential life-saving benefit, also huge. So the risk is often justified.
But flip that scenario.
Right. Take someone using an over-the-counter antihistamine for a mild cold, even a predictable minor side effect like drowsiness.
Could be totally unacceptable if they need to drive or operate machinery.
Exactly. The risk, even if small, just isn't worth the minor benefit of easing a sniffle in that situation. The calculation changes completely based on the indication and the patient's life context.
And timing matters too, you mentioned. Effects aren't always immediate.
Oh, definitely not. That's a common pitfall. An adverse effect can pop up right away, sure, but it might only appear after weeks or months of use. Or, critically, it might only manifest after the drug has been stopped.
Really? even after stopping.
Yes, sometimes days or weeks later. So you always have to look backwards and forwards in the patient's timeline when investigating a potential reaction. It's not always simple cause and effect right after the pill.
Okay, so we've got the landscape mapped out. The terminology AE, ADE, ADR, and the fundamental risk-benefit reality. Now, let's move into classification. How do we categorize these reactions based on why they happen? This seems crucial for managing them.
Absolutely. This is the bedrock, really. The division into two main types, type A and type B. Understanding this difference is key to predicting and managing risk.
All right, let's start with the one we might have more control over. Type A, the augmented reactions.
Right. Type A reactions are, well, predictable. They're based directly on the drug's known pharmacology. It's essentially the drug doing what it's supposed to do, just too much.
Exaggeration of the normal effect.
Exactly. An augmented but qualitatively normal response. So if you give a beta blocker to lower heart rate, a type A reaction would be severe bradycardia, maybe even heart block, or profound hypotension. It's an overdose effect, pharmacologically speaking, even if the dose was technically normal.
So these are common.
Much more common than type B. They're clearly dose-related, more drug, bigger effect, higher risk, and crucially, they're usually preventable with careful dosing and monitoring, and they're typically reversible if you lower the dose or stop the drug.
Okay, so type A is basically an overaction predictable from the drug's mechanism, maybe happening because the patient isn't clearing the drug properly. Makes sense. Which leads us to the scary ones, type B.
Type B, sometimes called bizarre reactions. And yeah, these are the ones that keep clinicians up at night.
Why bizarre?
Because they are defined by the patient's unique biology, not the drug's intended action. It's something peculiar about that individual. Think immunologic reactions like allergies or genetic quirks that we call idiosyncrasy.
So completely unrelated to the drug's therapeutic goal.
Totally unrelated. They are much less common than type A, thankfully. They're often not dose-related. A tiny exposure can trigger a massive reaction in a susceptible person. And they tend to be much more serious, often requiring immediate and permanent withdrawal of the drug. Usually can't just lower the dose.
That sounds professionally challenging. Historically, type B meant managing huge risk with almost no warning, right? Like rolling the genetic dice.
That's exactly what it was. But here's where things are getting interesting looking ahead.
How so?
Well, some reactions previously considered completely bizarre, totally random type B events. We can now sometimes predict them.
Through genetics.
Yes, pharmacogenetics. If we know the specific genetic variation, say, in a metabolizing enzyme or a receptor that predisposes someone to that reaction, we can actually test for it beforehand.
Preemptive screening.
Right. Suitable phenotype or genotype testing. Personalized medicine, at its best, really aims to eliminate these bizarre reactions by identifying susceptible individuals before they ever get the drug. It's about making the unpredictable predictable.
Fascinating. Okay, before we dive into the dozen specific ways drugs cause harm, we need a way to talk about how bad a reaction is. The severity grading. Vital for reporting, I assume.
Absolutely vital for regulatory agencies like the FDA or EMA.
Yeah.
It standardizes how we communicate the seriousness. There are basically 4 levels.
Okay, level 1.
Minor. This means no specific treatment or antidote was needed. It didn't make the hospital stay any longer. It's an inconvenience, maybe, but it resolves on its own.
Got it. Next.
Moderate. Now we need intervention. This requires changing the drug therapy, giving a specific treatment like an antihistamine for a rash, or it prolongs the hospital stay by at least 1 day. It uses up resources.
Okay, then it escalates.
It does. Too severe. These reactions are potentially life-threatening. They might cause permanent damage to an organ, or they require intensive medical treatment, maybe even an ICU admission.
And the final level?
Lethal. This grade means the reaction directly or indirectly contributed to the patient's death.
Wow. So, minor, moderate, severe, lethal. A clear framework.
A necessary one for tracking the overall safety profile of medicines.
All right, we have the framework. Observation versus causality, ADA, ADR, mechanism, type A, type B, and severity. Now, let's get into the nitty-gritty, the specific ways drugs can actually cause harm. There are 12 main categories, right? Let's start with perhaps the most common, side effects.
Right. Side effects. These fall squarely into the type A predictable category. They're basically unwanted, but often unavoidable, effects that happen at normal therapeutic doses.
Unavoidable because they stem from the drug's main action.
Often, yes. They're pharmacodynamic effects.
Yeah.
Generally, they aren't intrinsically serious, but the context can make them dangerous.
Give us an example.
Okay, take prazosin, an alpha blocker used for hypertension. Its job is vasodilation. A predictable side effect is some postural hypotension, feeling dizzy when you stand up quickly.
Seems minor.
For a young, healthy person, it probably is. But imagine an elderly patient taking it. That same minor postural hypotension could cause them to fall and break a hip. Suddenly, that predictable side effect leads to a catastrophic outcome.
So the effect itself is type A predictable, but the consequence depends entirely on the patient and situation.
Exactly, and often the mechanism directly mirrors the therapeutic goal. Like atropine used pre-surgery to dry up secretions. The dry mouth side effect comes from that exact same anti-secretory action.
Or nitroglycerin for angina.
Perfect example. It works by dilating blood vessels. That relieves chest pain, but it also causes the side effects of headache and flushing through the very same vasodilation mechanism.
But sometimes the side effect is unrelated to the main job.
Yes, sometimes it's a different facet of the drug's action.
Yeah.
Think of older antihistamines like promethazine. Its anti-allergy effect is one thing, but it also causes significant sedation, which is pharmacologically distinct.
And interestingly, sometimes a side effect in one context is the desired effect in another.
Absolutely. Codeine is classic, causes constipation as a side effect when you're treating cough. But if you're treating traveler's diarrhea, that constipation is the therapeutic goal.
It's fascinating how observing these side effects has actually driven drug discovery, too.
Oh, hugely. The story of sulfonamides is a great example. Early ones were antibiotics, but doctors noticed they caused low blood sugar hypoglycemia and also acidosis as side effects.
Just observations initially.
Right. But researchers dug into why. And that investigation led directly to developing whole new classes of drugs. The sulfonylureas for diabetes, based on the hypoglycemia effect, and diuretics like acetazolamide, based on the acidosis effect. Side effects paved the way.
Okay, category 2, secondary effects. How are these different from side effects?
Secondary effects are more indirect.
Yeah.
They are consequences of the drug's primary action, but not the action itself, more like a domino effect.
Like the system reacting to the drug's influence.
Yeah, that's a good way to put it. The classic example is broad-spectrum antibiotics, like tetracyclines.
Okay.
Their primary action is killing lots of different bacteria. The secondary effect is that by wiping out the normal gut or vaginal flora, they remove the natural competition. This allows opportunistic bugs like Candida yeast to overgrow, leading to thrush or other superinfections. The drug didn't cause the yeast infection directly, it just created the conditions for it.
Ah, I see. Indirect consequence. Any other examples?
Corticosteroids are another major one. Their primary action is suppressing inflammation and the immune system. A critical secondary effect of weakening host defenses is that the body might lose control over infections it was previously keeping in check, like latent tuberculosis. The TB could reactivate. The steroid didn't cause TB, but its action allowed it to emerge.
Moving on to category 3, toxic effects. This sounds like an escalation from side effects. More severe type A.
Exactly. Toxic effects are the result of excessive pharmacological action. This is usually due to overdose, either absolute or relative.
Define those. Absolute versus relative overdose.
Absolute overdose is simple. Someone took way too much drug, accidentally, intentionally, whatever. The dose was just too high.
Okay.
Relative overdose is more common in clinical practice and maybe more insidious. This is when a standard, normally therapeutic dose becomes toxic because the patient can't handle it properly.
Like impaired elimination.
Precisely. The classic is giving a normal dose of a kidney-cleared drug, like the antibiotic gentamicin, to someone who has underlying kidney failure, maybe undiagnosed. The drug builds up to toxic levels, even though the dose given was technically correct.
And the effects are predictable.
Entirely predictable and dose-related. They can range from functional changes like high doses of atropine causing confusion or delirium, all the way to actual tissue damage, like paracetamol overdose causing severe liver necrosis.
Sometimes it's just an extreme version of the therapeutic effect.
Yes. Barbiturates causing sedation is therapeutic. Overdose causing coma is toxic extension. Digoxin slowing heart rate is therapeutic. Overdose causing complete heart block is toxic extension. Heparin thinning blood is therapeutic. Overdose causing major bleeding is toxic extension.
But sometimes the toxicity comes from a different action of the drug.
Also very common. Morphine is a great analgesic, but its toxic effect in overdose is respiratory failure, a separate mechanism. Imipramine is an antidepressant, but its toxicity involves dangerous cardiac arrhythmias. Streptomycin treats TB, but its toxicity involves damage to the vestibular system in the ear. Different facets of the molecule cause trouble at high concentrations.
Which brings us logically to outright poisoning, category 4. This is where toxicology really takes center stage.
Right. We go back to that old saying, the dose makes the poison. A poison is basically any substance, drug, or otherwise that endangers life by severely disrupting vital functions.
So it includes more than just drugs.
Oh, yes. Household chemicals, industrial agents, pesticides, plant toxins, animal venoms. It's a broad field. But drug overdoses is a major part of clinical toxicology.
And the management is systematic, right? Emergency situation.
Absolutely. Top priority is always resuscitation and maintaining vital functions. The ABCs, airway, breathing, circulation. Ensure the airway is clear, support breathing, often with 100% oxygen because respiratory drive is commonly depressed, and maintain blood pressure and heart function with fluids, sometimes pressor drugs.
What else immediately?
Control seizures if they're happening, usually IV lorazepam is first line. And check blood sugar. Hypoglycemia can mimic or worsen poisoning symptoms. You stabilize the patient first.
While that's happening, you're also trying to stop more poison getting in. Decontamination.
Correct. Termination of exposure. Get contaminated clothes off. Wash skin and eyes thoroughly if it was external. For ingested poisons, historically we thought about emptying the stomach.
Emesis. Making them vomit.
Almost never done in hospitals anymore. Too risky, especially aspiration. Gastric lavage, stomach pumping, is also used much, much less.
Why is that?
Big limitations. You absolutely cannot do it if the patient is comatose or unstable, high risk of aspirating stomach contents. Also contraindicated if they swallowed corrosive agents, like strong acids or alkalis or certain CNS stimulants. And critically, it's generally not helpful if more than, say, 2 hours have passed since ingestion. The poison has likely moved past the stomach.
So stomach emptying is rare now. What's the main strategy for ingested poisons?
Preventing absorption using activated charcoal.
How does that work?
Charcoal has a massive surface area. It works by adsorption, binding the poison molecules onto its surface in the gut, preventing them from being absorbed into the bloodstream. We give a large dose, usually a slurry of 20 to 40 grams.
Does it work for everything?
No, and that's critical for professionals to remember. Charcoal is not effective for certain things. It doesn't bind well to strong acids or alkalis, heavy metals like iron or lithium, alcohols like ethanol or methanol, or hydrocarbons like gasoline. You need to know the exceptions.
Okay. After trying to prevent absorption, can we speed up elimination of what's already in the system?
Sometimes, but methods like forced diuresis, giving lots of IV fluids and diuretics, are also less favored now.
Risks outweigh benefit.
Often, yes. Risk of fluid overload, electrolyte imbalances, and it's actually not that effective for many poisons. The modern approach for enhancing elimination, when needed for specific severe poisonings, is hemodialysis or sometimes hemoperfusion.
Dialysis, like for kidney failure.
Exactly. It's much more efficient at removing certain drugs from the blood, especially things that are water-soluble, not highly protein-bound, and have a small volume of distribution. Think of drugs like phenobarbital, lithium, salicylates like aspirin, valproate. Dialysis can be life-saving in those specific severe cases.
Okay, let's shift back from overdose to reactions at normal doses. Category 5, intolerance. How is this different from, say, a severe side effect?
Intolerance is about individual sensitivity. It's when a patient shows the characteristic toxic effects of a drug, but at a therapeutic dose that most people tolerate fine.
So it's like they have a really low threshold for the drug's toxicity.
Exactly. Think of the standard dose response curve in a population. Most people are in the middle. People with intolerance are way over on the hypersensitive left tail of that curve. It's still fundamentally a type A mechanism, an exaggerated response to the known pharmacology. But it looks like a type B reaction because it happens unexpectedly at a normal dose.
Any examples?
Sure. Some children might develop muscle spasms, dystonias, after a standard dose of the antipsychotic triflupromazine. Or someone might get ataxia, clumsiness after just a couple of doses of the anti-seizure drug carbamazepine. Or getting severe nausea and abdominal pain from just one tablet of chloroquine for malaria prevention. Their body just can't handle a normal amount.
Which contrasts with category 6, idiosyncrasy. You mentioned this is the true type B.
Yes, idiosyncrasy is the classic definition of a type B, or bizarre reaction. It's a genetically determined, qualitatively abnormal way of reacting to a drug. The drug interacts with some unique genetic feature of that individual.
So the reaction is not an exaggeration of the known effect. It's something completely different.
Completely different, often unpredictable, and not related to the main pharmacology. It's a true peculiarity of the patient's interaction with the chemical.
Examples here.
Well, some individuals might get paradoxical excitement or confusion from barbiturates, which normally cause sedation. That's idiosyncratic. The most feared example, historically, was the aplastic anemia caused by the antibiotic chloramphenicol.
Aplastic anemia.
Okay.
Complete bone marrow failure.
Yes.
Yeah.
Devastating. And it was non-dose related, extremely rare but fatal when it occurred. It had nothing to do with chloramphenicol's antibiotic action. It was down to a specific, rare genetic susceptibility in those individuals. That's pure idiosyncrasy.
Okay, the other major type B category is drug allergy or hypersensitivity. Number 7, this is immune-mediated, right?
Correct. This is the immune system mistakenly identifying the drug, or a complex involving the drug, as a foreign threat and launching an attack. It's completely unrelated to the drug's intended pharmacological effect.
And it needs prior exposure.
Yes, crucially, there's usually a sensitization period, maybe 1 to 2 weeks on first exposure, where the immune system learns to recognize the drug. Subsequent exposures then trigger the reaction, often even with tiny doses.
You mentioned the drug molecule itself might be too small, the hapten concept.
Right. Most drugs are small molecules, chemically speaking. Too small on their own to be immunogenic, to trigger an immune response. They act as haptens or incomplete antigens.
So how do they become allergenic?
They have to bind, usually covalently, to a larger endogenous molecule in the body, typically a protein like albumin. This drug-protein complex then becomes large enough and foreign-looking enough to be recognized by the immune system as a full antigen.
What are the telltale signs that suggest an allergic reaction?
There are cardinal features clinicians look for. The reaction often looks like known allergies to things like food or pollen. There's usually a poor correlation with the drug dose. A tiny amount can cause a big reaction. You need that initial sensitization period. And critically, you should see a positive de-challenge. The symptoms get better when you stop the drug. Re-challenge, giving the drug again, would confirm it, but is often too risky.
Okay. Now, within allergy, there are different types based on the immune mechanism, right? Like the Gell and Coombs classification.
Exactly. 4 main types. And understanding the mechanism helps predict the timing and severity.
Let's start with type I, the immediate one.
Type I anaphylactic reactions. This is immediate hypersensitivity. It's mediated by preformed IgE antibodies that are already stuck onto the surface of mast cells and basophils from a prior exposure.
So the immune system is primed and ready.
Primed and ready. When the drug, as an antigen, encounters these IgE antibodies, it triggers immediate degranulation of those cells, releasing a flood of potent mediators, histamine, leukotrienes, prostaglandins.
Lead.
Rapid onset symptoms, within minutes usually. Urticaria, hives, angioedema, swelling, often lips, face, throat, bronchospasm, wheezing, and in the worst case, life-threatening anaphylactic shock with cardiovascular collapse.
Are there warning signs?
Often, yes.
Huh.
Patients might describe initial herald symptoms like tingling or itching, paresthesia, flushing, dizziness, a feeling of anxiety or impending doom, which can progress rapidly to fainting or collapse. It's a true medical emergency.
Okay. Type 2.
Type 2, cytolytic reactions. This involves different antibodies, mainly IgG or IgM. These antibodies bind directly to antigens on the surface of the patient's own cells, maybe red blood cells, platelets, or white blood cells that have the drug or metabolite attached.
And then what happens?
This antibody binding activates the complement system or attracts killer cells, leading to the destruction, the lysis of those targeted cells. Clinically, this causes things like drug-induced hemolytic anemia, red cell destruction, thrombocytopenia, platelet destruction, or sometimes even aplastic anemia if bone marrow stem cells are targeted.
So, direct cell killing mediated by antibodies. Type 3.
Type 3, immune complex reactions, also called Arthus reactions. Here, antibodies, again usually IgG, bind to the drug antigen while it's still circulating in the blood, forming soluble antigen-antibody complexes.
Okay, circulating complexes, what do they do?
These complexes get deposited in the walls of small blood vessels, especially in places like the skin, joints, and kidneys. They trigger complement activation and attract inflammatory cells, causing inflammation and damage to the vessel wall's vasculitis.
What does that look like clinically?
It can cause skin rashes, fever, joint pain, a syndrome called serum sickness,
Or
more severe delayed skin reactions like Stevens-Johnson syndrome. These typically develop over several days, say 3 to 10 days after exposure, so it's a retarded or delayed onset compared to type I.
Right. And finally, type 5.
Type 5, delayed type hypersensitivity, DTH. This one is fundamentally different because it's not mediated by antibodies at all. It's purely cell-mediated. Exactly. Sensitized T lymphocytes recognize the drug antigen, often presented on skin cells. Upon re-exposure, these T cells get activated and release chemical messengers called lymphokines. These lymphokines recruit and activate other inflammatory cells, mainly macrophages and granulocytes, leading to localized inflammation.
What kind of reactions does this cause?
The classic example is allergic contact dermatitis, like the rash you get from poison ivy, but caused by a drug applied to the skin or even taken systemically. Certain types of drug-induced photosensitivity also fall under type 5. Because it involves cell recruitment and activation, it takes time to develop, usually 2 to 3 days.
Okay, 4 distinct mechanisms. Now, crucially, the treatment, especially for the most urgent one, type I anaphylaxis. What's the absolute must-know?
For anaphylaxis, immediate action is life-saving. First, stop the offending drug immediately. Get the patient lying down, ideally with legs elevated if they're hypotensive, to help blood return to the heart. Ensure high-flow oxygen, and if needed, start CPR.
And the one drug that can reverse it?
Adrenaline, epinephrine. It's the only truly life-saving drug in acute anaphylaxis. It counteracts vasodilation, reduces swelling, opens airways.
How is it given? Dose?
The standard adult dose is 0.5 milligram, which is 0.5 milligil of the 1.1000 solution, given intramuscularly, typically into the outer thigh muscle. Repeat every 5–10 minutes if needed.
Why IM, not SV?
This is a critical safety point. Rapid Phe injection of undiluted adrenaline can cause fatal cardiac arrhythmias or extreme hypertension. IM gives a rapid enough absorption for most cases and is much safer. 4V adrenaline should only be considered in profound shock refractory to IM doses, and even then it must be highly diluted and infused very slowly with continuous cardiac monitoring, usually in ICU setting.
So IM first is the rule. What about other drugs? Antihistamines? Steroids?
They are important adjuvants, but they do not replace adrenaline. H1 antihistamines like IV chlorpheniramine or pheniramine help relieve itching and hives. 4V glucocorticoids like hydrocortisone take hours to work but are crucial for preventing biphasic or prolonged reactions, especially in severe cases or asthmatics. They help settle the inflammation long term.
So, adrenaline saves the life? Antihistamines and steroids help manage the aftermath.
That's a good summary. And one more clinical point. Skin testing for drug allergies.
Useful.
Often unreliable, unfortunately.
Yeah.
Lots of false positives and false negatives. So a negative skin test doesn't definitively rule out an allergy, especially a severe one like anaphylaxis. Clinical history is usually much more important.
And which drugs are common culprits for allergy?
The list is long, but some stand out. Penicillins and related antibiotics are probably number one. Aspirin and other NSAIDs. Sulfonamides, both antibiotics and other types. ACE inhibitors, known for causing angioedema. Those are frequent offenders.
Okay, moving to number 8, photosensitivity. This is the skin reacting to sunlight because of a drug.
Exactly. The drug essentially sensitizes the skin to ultraviolet radiation. There are 2 main ways this happens.
2 mechanisms.
Yes. The first and more common one is phototoxicity.
Phototoxic, like a direct burn.
Pretty much. The drug, or one of its metabolites, accumulates in the skin. When exposed to UV light, mainly the shorter wavelength UVB, it absorbs the energy and generates reactive oxygen species that directly damage skin cells. It looks like an exaggerated sunburn, redness, swelling, maybe blistering. It's dose-dependent and is essentially a type A toxic effect localized to the skin.
Which drugs do this?
Tetracycline antibiotics are classic phototoxic agents. Also, things like tar products used for psoriasis.
Okay. And the second mechanism?
Is photoallergy. This is different. It's a true immune response, like type IV hypersensitivity.
How does that work?
Here, UV light, often the longer wavelength UVA, chemically alters the drug in the skin, creating a new compound that the immune system recognizes as foreign. This triggers a cell-mediated immune response.
What does it look like?
It often resembles allergic contact dermatitis, an itchy eczematous rash, sometimes spreading beyond the sun-exposed areas. And because it's immune-mediated, it can happen with lower drug doses and might persist even after the drug is stopped.
Examples of photoallergic drugs.
Sulfonamides again. Also, drugs like chlorpromazine, certain NSAIDs like ketoprofen, and carbamazepine.
Prevention seems obvious.
It is. Avoid excessive sun exposure if you're taking a photosensitizing drug. Wear protective clothing. And use broad-spectrum sunscreens that cover both UVB and UVA, with a high SPF, like 15 to 60 or higher.
Right. Let's shift gears significantly now. Categories 9, 10. These deal with the complex behavioral and neurological effects, starting with drug dependence and addiction. Number 9. These terms get used interchangeably, but they're distinct, right?
Critically distinct, yes, both clinically and socially. Let's start with drug dependence.
Okay.
Dependence is fundamentally a physiological state. It's produced by repeated drug administration, causing the body to adapt what we call neuroadaptation. The body changes its normal functioning to accommodate the drug's presence.
So it needs the drug to feel normal.
Exactly. Continued presence of the drug is required just to maintain physiological equilibrium. If you suddenly stop the drug, the body's adaptations are unopposed, leading to a characteristic physical withdrawal syndrome or abstinence syndrome. This used to be called physical dependence.
Which drugs cause this kind of dependence?
Classic examples are opioids, like heroin or morphine, barbiturates,
Yeah.
alcohol, benzodiazepines, like Valium or Xanax. Stopping these abruptly causes very real, often severe, physical withdrawal symptoms.
What about stimulants? Cocaine, amphetamines.
Interestingly, pure stimulants typically produce minimal or no significant physical dependence or withdrawal syndrome in the same way opioids or alcohol do, which leads us to addiction.
Okay, so drug addiction, how is that defined?
Addiction is defined by behavior. It's a compulsive pattern of drug use characterized by an overwhelming involvement with procuring and using the drug, often taking precedence over everything else in life: work, family, health.
And the driver isn't just avoiding physical withdrawal.
Not primarily. The driving force is often the drug's rewarding or pleasurable effects, and the intense craving or psychological distress felt when the drug is absent. This used to be called psychological dependence.
So here's the crucial distinction professionals need to grasp.
Yes, dependence, the physiological adaptation and withdrawal, is a strong driver for continued use if it's present, but it is not essential for addiction.
What do you mean?
Meaning you can be severely addicted to drugs that cause little or no physical dependence. Cocaine and amphetamines are prime examples. The addiction is driven by the intense euphoria and craving, the psychological component, not by avoiding physical sickness.
What makes a drug more addictive then?
A key factor is reinforcement. How strongly does the drug produce effects that make the user want to take it again? Generally, drugs that act quickly and produce intense pleasure have higher reinforcement potential.
Like route of administration matters.
Hugely. Inhaled drugs, like crack cocaine, or intravenously injected drugs like heroin, hit the brain very fast, causing a rapid, intense high. This makes them much more reinforcing and addictive than, say, swallowing a pill that takes time to absorb.
And how does drug abuse fit in?
Drug abuse is the broadest term, really. It refers to any use of a drug that deviates from accepted medical or social norms. It covers a wide spectrum. We often see two main patterns.
Which are?
Continuous use, where the person tries to stay under the influence most of the time, think chronic alcoholism or daily opioid use. And occasional or binge use, where the drug is taken intermittently, often for pleasure or escape, like weekend cocaine use, taking psychedelics occasionally, or binge drinking.
You sometimes hear the term drug habituation. Is that useful?
It used to be used to describe less intensive involvement, where withdrawal caused only mild discomfort. But honestly, the lines between habituation and addiction are blurry. It's probably better to think in terms of the spectrum of addiction severity rather than trying to make habituation a distinct category. It often just causes confusion.
Okay, closely related is category 10, drug withdrawal reactions. We touched on this with dependence, but it applies more broadly too, right? Not just for drugs of loose.
Absolutely. This refers to significant adverse effects that happen when you suddenly stop or interrupt a drug that a patient has been taking long-term for a therapeutic reason. It's often a rebound effect.
Why'd it happen?
Again, it's due to those adaptive changes, the neuroadaptation, that occurred during long-term therapy. The body got used to the drug being there, maybe downregulating receptors or changing neurotransmitter levels.
Yeah.
When you suddenly remove the drug's influence, the system rebounds, often overshooting in the opposite direction.
Can you give examples with therapeutic drugs?
Sure, several critical ones.
Yeah.
Suddenly stopping long-term corticosteroids can cause acute adrenal insufficiency, a potentially fatal crisis because the body's own cortisol production has been suppressed.
Serious.
Very. Stopping clonidine, in older blood pressure medicine, abruptly can cause severe rebound hypertension, sometimes dangerously high. Stopping beta blockers suddenly, especially in someone with heart disease.
Risk of heart attack.
Yes, increased risk of angina, heart attack, even sudden death. The heart has become hypersensitive to adrenaline because the beta receptors were blocked for so long. Similarly, abruptly stopping anti-epileptic drugs can trigger rebound seizures, sometimes worse than before.
So the professional practice point is clear.
Crystal clear and non-negotiable for these types of drugs. Gradual withdrawal. You must taper the dose slowly over weeks, sometimes months, to allow the body systems to readjust gently. Abrupt cessation can be dangerous.
Okay, a particularly sensitive and critical area now. Category 11, teratogenicity, the potential for drugs to harm a developing fetus.
Yes, teratogenicity is the capacity of a drug when given to the mother during pregnancy to cause fetal abnormalities or birth defects. It's a huge concern because the embryo is incredibly dynamic, and drug effects during development can lead to permanent, irreversible structural problems.
And the field was tragically shaped by one major disaster, wasn't it?
Tragically, yes. The thalidomide disaster in the late 1950s and early 60s. Thalidomide was marketed, incredibly, as a safe sedative and anti-nausea drug for pregnant women, particularly for morning sickness.
What happened?
Thousands of babies were born worldwide with severe limb defects, most notably phocomelia seal limbs, where hands and feet are attached directly to shortened or absent arms and legs. Also, other defects involving ears, eyes, heart, internal organs. It was devastating and led to a complete overhaul of drug safety regulations globally, demanding proof of fetal safety before approval.
That disaster taught us a lot about when the fetus is most vulnerable, didn't it? The timing matters hugely.
Critically, there are distinct stages. The first is very early, fertilization and implantation, roughly the first 17 days after conception. Exposure here often leads to an all-or-none effect.
Meaning?
Either the damage is so severe the pregnancy fails very early, often before it's even recognized, or the embryo recovers fully with no lasting defects. Significant structural malformations are less common from exposure in this very early phase.
Then comes the critical window.
Yes, the period of organogenesis, roughly from day 18 to day 55 of gestation. This is when all the major organs and body structures are being formed. Exposure during this time is when drugs are most likely to cause major structural birth defects, the classic teratogenic effects. This is the period of maximum vulnerability.
And after that, the third stage.
From about day 56 onwards, it's mainly growth and development. The basic structures are formed, but organs are maturing, growing, and refining their function. Drug exposure here is less likely to cause gross structural defects, but can cause functional problems, growth restriction, or issues with specific organ development.
Like what?
For example, ACE inhibitors taken later in pregnancy can impair fetal kidney development and cause lung hypoplasia. NSAIDs taken late can cause premature closure of the ductus arteriosus, a vital fetal blood vessel, leading to heart problems in the newborn. So risks exist throughout pregnancy, but the type of risk changes.
Are there well-known human teratogens we should be aware of? Specific examples?
Absolutely. Warfarin, the anticoagulant, can cause fetal bleeding and characteristic facial abnormalities like a depressed nasal bridge. Valproate, an anti-seizure drug, is strongly linked to neural tube defects like spina bifida. Isotretinoin, Accutane, used for severe acne, is a potent teratogen causing severe craniofacial, heart, and central nervous system defects. The list is sadly quite long.
How do regulators categorize this risk? I know the US FDA had letter grades.
They did the A, B, C, D, X categories. Category A was safest, proven safe in human studies. X was absolutely contraindicated, proven risk outweighs any possible benefit. B, C, and D were intermediate levels based on animal data or limited human data.
But that system is changing.
Yes, its utility was questioned. The letter grade often oversimplified a complex risk. The FDA has moved towards a more narrative format, the Pregnancy and Lactation Labeling Rule, PLLR, which provides more detailed summary of the risks, clinical considerations, and available data. But the underlying principle remains. Avoid all drugs during pregnancy if possible, especially during the first trimester, organogenesis, unless the benefit to the mother clearly outweighs the potential risk to the fetus. And always use the lowest effective dose for the shortest possible time. One positive note: folic acid supplementation before and during early pregnancy can significantly reduce the risk of neural tube defects, both spontaneous and potentially some drug-induced ones.
Okay, category 12, related to genetic damage but distinct from teratogenicity, mutagenicity, and carcinogenicity.
Right. Mutagenicity is the capacity of a chemical, often through its reactive metabolites, to cause changes in the DNA sequence itself, mutations. Carcinogenicity is the capacity to cause cancer.
How are they linked?
Often, mutagenicity is the first step. The drug or metabolite interacts directly with DNA, maybe covalently binding to it, causing structural changes. If these mutations occur in genes that control cell growth and proliferation, like protein-encode genes or tumor suppressor genes, they can initiate the process of cancer development.
But cancer takes time.
Yes, carcinogenesis is usually a multi-step process with a very long latency period, often 10, 20, even 40 years after the exposure before a clinical cancer develops.
Which drugs carry this risk?
Many anti-cancer drugs themselves, ironically, are mutagenic and carcinogenic. The risk is accepted because they're treating an existing cancer. Radioisotopes used therapeutically. Long-term exposure to certain hormones like estrogens has been linked to some cancers. And of course, tobacco smoke is loaded with carcinogens.
How is this handled regulatorily?
Drugs found to have significant mutagenic or carcinogenic potential in testing are generally not approved for marketing, or they are withdrawn, unless their use is absolutely essential for treating life-threatening conditions where the long-term cancer risk is considered an acceptable trade-off against the immediate benefit.
And our final category, number 13, drug-induced diseases, sometimes called iatrogenic diseases. How is this different from a side effect or toxicity?
The key difference is persistence. Iatrogenic means physician-induced. These are functional disturbances or actual diseases caused by a drug which persist and often require their own treatment even after the offending drug has been stopped. They aren't just transient effects that go away when the drug clears.
So, lasting damage.
Often, yes. Lasting structural or functional changes. Think of peptic ulcers caused by chronic high-dose NSAI or corticosteroid. Use the ulcer remains after the drug is stopped and needs treatment. Or Parkinsonism symptoms mimicking Parkinson's disease induced by certain older antipsychotics, which can sometimes persist for months or even permanently after withdrawal.
Other examples.
Drug-induced hepatitis, for instance, from the anti-TB drug isoniazid. It can cause liver damage that requires significant medical care long after the isoniazid is stopped. Or drug-induced lupus, DLE, from drugs like hydralazine or procainamide. These are essentially new disease states triggered by the medication.
Okay, we've covered a huge amount of ground on how drugs can cause harm. 12 distinct categories. Now let's bring it back to practice. How do we, as professionals, actively prevent these adverse effects, or at least minimize the risk?
That's the crucial application, isn't it?
Yeah.
While we can't eliminate all risk, especially unpredictable type B reactions, there are absolutely core practices that significantly reduce the likelihood of harm, particularly the more common type A effects. There are about 7 key pillars.
Right, pillar number 1.
Avoid inappropriate use. Simple but foundational. Does the patient actually need this drug for their specific clinical condition? Is there a non-drug alternative? Are we just treating a number or a minor symptom without clear benefit? Overprescribing is a major source of adverse effects.
Okay, number 2.
Use the right dose, route, and frequency tailored to the individual patient. Consider their age, weight, kidney function, liver function, other illnesses. All the variables that affect how you'll handle the drug. This avoids relative overdose and minimizes predictable type A toxicity.
Makes sense. Number 3.
History, history, history. You must elicit and carefully consider any previous history of adverse drug reactions the patient has experienced. If they reacted badly before, especially if it sounds like an allergy, avoid that drug and related ones.
And related to that, number 4.
Specifically ask about a history of general allergic diseases, asthma, hay fever, eczema, food allergies. Patients with this atopic background have a significantly higher risk of developing drug allergies too. It flags them for extra caution.
Good point. Number 5.
Check for potential drug interactions, especially crucial in patients on multiple medications, which is common. Are there interactions that could increase toxicity, particularly pharmacokinetic ones involving liver enzymes like CYP inhibition or induction, that can dramatically raise or lower drug levels unexpectedly? Use interaction checkers.
Vital and polypharmacy. Number 6.
Adopt the correct drug administration technique. This sounds incredibly basic, but errors here cause harm. For instance, infusing vancomycin too rapidly causes red man syndrome, a histamine release reaction. Giving potassium IV too quickly can be fatal. Technique matters.
Absolutely. And the final pillar, number 7.
Carry out appropriate laboratory monitoring when needed. Certain drugs require it. Monitoring prothrombin time, INR, for warfarin is essential to prevent bleeding or clotting. Checking serum levels for drugs with a narrow therapeutic index, like lithium, digoxin, or certain anti-epileptics, helps ensure efficacy while avoiding dose-related toxicity.
So, 7 key practices that really form the bedrock of safe prescribing. Avoid inappropriate use, tailor the dose, get the history right, check for interactions, use correct technique, and monitor when necessary.
If we consistently do those things, we can prevent a large proportion of adverse drug effects, especially the predictable type A ones.
Okay, let's synthesize this. We've gone deep into the terminology, the mechanisms, the specific types of harm, and prevention. What's the core takeaway for achieving that elite understanding?
I think the absolute foundation is grasping that difference between type A and type B. Type A, augmented, predictable from pharmacology, dose-related, often manageable. Type B, bizarre, patient-specific, often immune or genetic, unpredictable, often serious. That distinction guides almost everything in risk assessment.
And bridging the gap between seeing something happen and proving the drug caused it. That's where pharmacovigilance comes in.
Exactly. Pharmacovigilance is the ongoing science and activity dedicated to detecting, assessing, understanding, and preventing adverse effects. It's the system that takes those initial raw reports of adverse drug events, ADEs.
The may or may not be related observations.
Right, and applies rigorous causality assessment methods to determine if they qualify as adverse drug reactions, ADRs.
You mentioned the Naranja scale earlier.
That's one well-known example. There's several algorithms. They assign points based on factors like, did it happen after the drug was given? Did it improve when the drug was stopped, D-challenge? Did it reappear if the drug was started again, re-challenge? Is it a known reaction? Are other causes ruled out? Based on the score, causality is graded, definite, probable, possible, doubtful.
So it's a structured way to move from suspicion to probability.
Precisely. It's this scientific rigor applied to post-marketing surveillance data that allows regulators to detect new safety signals, update drug labels, or even withdraw drugs from the market if the risks are found to outweigh the benefits after approval. It's a continuous cycle of learning.
So wrapping up, we understand the complexity now. We know many effects stem from the drug's intended actions, type A, while the most dangerous often come from patient uniqueness, type B. This leads to a fascinating final thought looking forward. You mentioned pharmacogenomics potentially predicting type B reactions. If that field truly matures, if we can reliably map an individual's genetic predispositions to these bizarre idiosyncratic reactions before prescribing, could we effectively eliminate type B harm?
That's the theoretical promise, isn't it?
If we could, what does safe prescribing even look like then? Would our entire focus shift almost exclusively to managing the predictable dose-related type A harm, knowing the catastrophic, unpredictable reactions have been screened out? Does it change the very nature of clinical risk management?
It would be a profound shift, moving from primarily reactive monitoring for the unpredictable to a much more proactive preventative stance focused on optimizing dose and managing known pharmacology. It fundamentally alters the risk equation we started with, a fascinating prospect for the future of medicine.
Something for all of us to consider as these technologies develop. Thank you for joining us on this deep dive into adverse drug effects and pharmacovigilance. We hope this detailed exploration helps you master this absolutely vital area of professional practice.